Yes.
I have a handful of questions to ask you, coming from call participants. I'll try and order them as best I can. Were you, in terms of the September 2004 plasma product notification, were you aware of any haemophilia centres that did not notify their patients? In particular, do you know whether St Thomas's Haemophilia Centre in London, under the directorship of Professor Savage, engaged in that notification process in September 2004?
I don't recall having information about any particular haemophilia centres. So I don't know. I can't answer that question.
So when we looked at the 2000 the report from the Health Protection Agency to the CJDIP, giving a summary of what had happened and so on, and we were looking at the outcome, and it said in there that the haemophilia people with bleeding disorders had been notified. Was that an assumption by the Health Protection Agency, or had they actually had? Do you recall whether you actually got feedback from particular haemophilia centres to say that they had actually engaged in the notification process?
Okay, I would have thought that this was a summary response from the UK HCDO, either to HPA or to the panel directly. I don't remember if UK HCDO made a sort of breakdown in their information. I don't recall any sort of presentation from them saying that these centres are doing it, these centres aren't doing it. I don't remember that. I mean, I don't know whether Frank Hill or Charles Hay have been witnesses, but that would be their kind of, for them to answer.
Again, sticking with the 2004 plasma product notification, in terms of the decision to have an umbrella notification, can you recall what weight was given to the individual patient's well-being as opposed to the question of public health protection when the decision was made to have an umbrella notification?
I think that decision was taken primarily for the patient's well-being. That was what it was the clinicians, the Haemophilia Doctors Association and the patient group who were both thinking the last thing patients want is for us to keep going back to them and changing the at-risk message. So that was the motivation for the umbrella group.
Again, sticking with plasma product notification in 2004, is it right to understand that your evidence that the notification for those patients with bleeding disorders was managed by, in the case of people with haemophilia, their haemophilia clinicians?
Yes.
Did the help, and that it was a matter between the haemophilia clinician and the patient as to whether there would be a follow-up appointment? The Health Protection Agency would expect one to be offered, but whether it was taken would be a question between a choice of the patient. Is that what the HPA understood?
I think we understood that the haemophilia clinicians were going to manage this and offer appointments. Yeah, they were doing it. We didn't know what the individual centres were offering to their patients or what the patients were accepting or asking for.
So the question of whether or not an appointment was going to be offered was a matter that was left to the decision of the haemophilia clinicians themselves.
I believe so.
And does it follow from that as well that the Health Protection Agency didn't have any communication with those patients with bleeding disorders as GPs? It was all the communication on the notification went through the clinician that dealt with their bleeding disorder rather than communicating with their GP as well.
Okay, so for that, I know we provided all the report, and it would say within the report and the toolkits. I don't recollect that there was a communication directly to their GPs. I think it was all through the UK HCDO. But I'd have to look at the documentation that we've discussed to sort of verify that. Yeah, I believe it was all through the haemophilia centres.
Again, sticking with the 2000...
Sorry, it would definitely have been because we didn't have these patient information IDs. We didn't have their details to contact the GPs.
Sticking again with the 2004 plasma product notification, with the benefit of hindsight, should there have been a list sent out to GPs of specialist counsellors with information about the risks in the 2004 notification, so that patients could have contacted them, or should a set of specialist counsellors have been made available to patients?
So the assessments that we did about how the notifications were received, there's one where we did a review with GPs and another where we did a small qualitative interview study based with patients. Those were not the haemophilia cohort. So therefore, I am not aware of any studies or audits that have looked into how the haemophiliacs received this information and to what degree, to actually quantify how much it went well or otherwise, and the response. And therefore, what was and also what provision there was around the country within the different haemophilia units. I mean, this would be you asked the question, it makes me think these are the questions I would then ask. So, therefore, I find it hard to say to you that there was this unmet need, and we should have provided, or it should have been provided, whatever, because what I imagine is there would be some reports of some individuals who would say, I didn't get enough support, but I can't quantify that among those 4,000. So it may well be that there wasn't sufficient psychological support within the trusts, but I can't. And then how would that best be answered on a trust basis of a trust employing a counsellor? I thought some trusts did employ counsellors actually, or whether was this. I don't. We have this central core of sort of specialist support, and I don't recall them saying they were getting overwhelmed in any way. They certainly were being involved, but they weren't saying, hey, we're getting 60 calls this week. They weren't saying that. So I think it's hard to quantify, but it's not saying, I'm not saying one way or the other kind of thing.
I may have misunderstood your evidence. I understood that this group of specialist experts was there to support the clinicians rather than the patients.
Well, sometimes the clinicians might have referred you, because we had nurses. Some of them were nurses, some were counsellors, and some were doctors. That whatever the need was, they could have been there. They were certainly able to support patients should they be required.
Again, still on the 2004 plasma product notification, should everyone have been offered and or written to by the Prion Centre to be able to have a specialist evaluation instead of leaving the communication of that up to the GP at the time they were notified? So we looked at the February 2006 material, but at the time they were notified, should that kind of material have been sent to the patient?
Are you saying from the point of view of entering their research studies, or are you talking about from the point of view of getting extra support?
So effectively for a specialist evaluation is what the question is, so that they could go and have a discussion with an assessment if necessary, or whatever would be suggested by the Prion unit.
Yeah, I mean, the Prion unit were most, as John Collins was explaining, were most keen to work with the patients who had received blood components where they were more concerned that this is a higher risk group. Would they have been able to offer more help? I mean, I think, again, I think the haemophilia doctors would have been able to refer their patients or help their patients access their prion clinic from 2004. I'm not sure whether, so I don't know whether any actually did. I mean, I know they received some help from, I know that they were approached and supported some at-risk patients. I'm not sure if it's specifically haemophilia at-risk patients.
Were there instances, to your knowledge, of the wrong people being notified that were at risk for public health purposes? For example, were you aware in 2004 that the Royal Free Hospital notified recipients, or do you know whether the Royal Free Hospital notified recipients of all blood products they were at risk, rather than those BPL products manufactured from the UK plasma?
I was not aware of that. I don't recall being aware of that.
And were you aware of any other instances of the wrong people being notified and then having to be contacted and denotified, other than in that 2013?
Well, there were other denotifications as the risk assessments changed, not just 2008, the other issues, but I wasn't aware of any people being incorrectly notified.
Was any support given to people that were denotified? Is that, and was any consideration given to that?
There would have been the same contact list available through the GP. They would have had the same list of, these are the national centres and these are the. They would have come to us if they wanted help, but there was no specific thing given other than a carefully worded information to support the clinician who was talking to the patient.
I'm now asking you a question about some of the evidence that Professor Collins gave. He gave some evidence last week about the product that he was involved in developing, the pre-soak, in order for instruments used on those at risk of VCJD could be decontaminated and sterilised. And I'm asked to ask you whether the HPA ever investigated the introduction of that product into the NHS, and whether that was part of HPA role.
Not that I'm aware of.
And another question in relation to surgical instruments, and I think this might arise from the passage we looked at in the article co-authored by you about this. Were quarantined endoscopes reserved for particular individual patients, or could they be used on any patient considered to be at risk?
I have to go back to the documents, but I think they were reserved for that individual patient. I think, in the best of my knowledge, talking about it now, I'd have to go back to the documentation.
And then lastly, you gave some evidence in relation to questions about those who had been a highly transfused group. And the question is this: as for the ethical issues about notifying those with multiple blood transfusions about the possible risk to them, what consideration was given to their right to be notified? And was it too difficult to even find out who these people were?
Sorry, could you just repeat that again? Sorry.
Yes. What consideration was given to their right to be notified?
The people who received many blood transfusions?
Yes.
Well, everything was... Well, I think the decision, first of all, I'm not sure what actually was resolved, because that was after I'd left CJD, and these discussions were going on and the risk assessments were going on. And there was a big discussion, one about what the actual risk was, which was basically based on modelled estimates, and then whether it was sufficient risk to actually take any action. And I think there was a lot of concern about the fact that people could move into a risk group, and you could see that this was going to happen. So at what stage did you start telling people? And then they were thinking, well, the doctors might tell all their patients who've had 100. Yeah, at what level are they going to start telling people? Because they just want, so it was very difficult to work out, to see how it was going to work. As far as people's right for the information, I think, yes, I mean, the panel sort of had that fundamental, I mean, in the framework document, it sets out all their principles about the right for people to know what's happened to them. But I think it was just one of the many difficulties in that particular piece of work. And then, interestingly, as that was going on, then the blood risk assessments changed. I think they redid it in 2012, 13, after I'd left. And then the whole levels at what we considered to be highly transfused changed as well. So you could see how difficult it was as the information was coming in. And also there was another uncertainty. No one really knew how many people this was going to be. And that, again, made the Department of Health, I mean, that again, slows it down, because you've got not just what's the uncertain risk and how do you manage it, but how many people are you talking about? So there's a lot of complications with that particular.
And the second part of the question was it too difficult to even find out who these people were? So what was the difficulty in finding out who they were?
Working out, I mean, as we just discussed with the tracing of batches, I think when you're trying to figure out who has received how many doses of blood, I mean, I think we found this out with the pre-surgical risk assessment. It's not really recorded in any uniform way, and each hospital will sort of look through their haematology lab data, and it might be variable, and then could they find out what someone had received when they were living in a different part of the country? And it was a difficult process. I mean, there's been lots in the press about NHS IT systems and stuff, and this was back in the 80s, so.
Those are all the questions I have for participants that I'm going to ask Dr. Connor. Can I just turn behind me? No questions from her legal team. So do you have any questions?
I have questions on two topics. Could we please put back up on screen SCGV 301019_073. Now, the focus of these questions is on what is risk. And you say, at a later stage in your evidence, after you dealt with this, that you didn't really know what the risks were of transmission of VCJD through blood. Does that remain the position, generally speaking?
In 2003?
Yes, the risk of developing CJD is unknown, you said.
Well, we had one transmission, but then again, it was possible that the person who was transfused had got VCJD through diet. So it wasn't proven that was their route of transmission. Is that what you mean?
And well, even if it was, you wouldn't know what the risk was in terms of the number of those receiving blood who would ultimately succumb.
Yes.
That it is generally right that this was a situation of considerable lack of information.
Yes.
So can you help me with this? When you look at this document here on the screen, and you see the expression, do I need to know about this? You say the risk appears to be very small. Thank you.
Yeah.
Can we come out of that, please? Out of the highlighting. Thank you. If we go down to, am I a risk to other people? There's a small possibility that BCGD could have been passed on to you. So there is a very small risk of something and a small possibility of transmissibility. Can I introduce your, before you answer, can I tell you that in general a lawyer will assess how big a risk is by looking at two things. One is the likelihood of it occurring, and the second is the seriousness of it if it does. So if you like, a risk of significant magnitude could be a very small risk of catching a very serious terminal illness. Take the risk of Ebola, for instance. If you happen to know that there's very little risk of it coming, but it might, but if you get it, it's very serious, that could be regarded as a risk of some magnitude, particularly in certain circumstances. On the other hand, a risk where it's very likely to get it, the common cold, for instance, might not be a very big risk because it's not very serious if you do, in general terms. So that's the way a lawyer will generally look at assessing the magnitude or size of a risk. How did the HPA do it?
Okay, I don't think it was quite
so analytical.
It's quite as structured as that. I mean, it is interesting. I mean, you're looking at this document now with the benefit of hindsight, you're thinking, oh my God, I wouldn't write it like that today, kind of thing. I suppose I'm thinking now, well, there was the journey. If you think about the years before the panel did this notification, when the line was, and there are lots of documents sort of saying, we can't tell anyone, we don't know what to say to people, let's not tell. So I suppose I'm seeing this document which I'm looking at now thinking, God, I want to scribble over it and change it. And thinking, well, it was a sort of continuum from the kind of don't tell anyone anything to giving everyone, well, 4 people out of 20, the full details. And this is kind of on that start of that journey. So, yes, I'm with you. I'm looking at this saying, I would want to say uncertain, and I'd want to edit this document now, but that's what it was said at the time. And maybe I'm seeing it as, well, maybe they felt that this was the least terrifying way to say something that hadn't been said before. I don't think it was kind of as quantified as the structures as what you're saying. I mean,
if one was to apply the structure which I just set out, what was known, undoubtedly known, was the seriousness if you do get it. Mm. But not the risk of transmission is something perhaps which was uncertain. So the very small risk, in general terms, doesn't really sit very well in terms of concept with the small possibility it could have been passed on. Because the one is very small, the other is small. One's an overall assessment, the other one is an assessment of the risk of transmission, as it reads.
Yes, I think this, if you look at this, I think if you can go to the next page just to see the whole document as a whole. Yeah, I mean, it's impossible. You've got a very small risk that you're going to die of this. It's a really hard message to put across, and I think, we did our best. And that would have been discussed. I know that Noel Gill and Mike Painter their names were on some of those letters in 2003. And Mike was on the panel. So I'm thinking, I can't remember now who got into the wording of this particular document, but it would have been through lots of people.
Well, you told us it had been very carefully considered.
Yeah, so it would have been very carefully considered, but and we're looking at it now thinking, would I word it like that now? No. Was it appropriate wording for the time? It's what we came up with as a sort of way forward at the time. And then as we discussed earlier, it changed as we went on. Yeah, it was a really difficult message to tell people.
The other question about risk is this. The one case by the time this was produced in 2003 of someone who had got a route of transmission through blood or blood products showed that there was a very considerable lag time between the date on which the product was taken and the time that the disease manifested itself. So you've got a very long incubation period. Now that was pretty well known, wasn't it? Or appreciated at the time. So was there any way of knowing at all how many cases might already be in the pipeline to establish what the risk was?
How many people had received blood?
Well, if you have a disease with an incubation period, if it's a short incubation period, on the whole, transmission followed by illness or disease, that's easy. But if you have something like HIV, where you have infection, which may be asymptomatic for some years before it begins to manifest itself, if it ever does, the natural course of the disease is it will, probably, in symptoms. During that period, the person who is infected but doesn't know it may be capable of transmitting it. So, if that's so for HIV and was known as an example by the time you got to 2003, when you got to CJD and you know that there is a long period during which there is no manifestation of the illness, how do you know what's waiting, what's already in the system, as it were?
You mean as far as the modelling for how much there is in the population?
It's really coming back to the same question of really what was there any information at all to support the idea that it was a small or very small risk, as opposed to saying, well, we don't know, but there haven't been very many recorded cases of transmission.
Well, there was modelling of, James Ironside was referring to the modelling that was done, I think it was based at Imperial, where they were trying to model what potential cases of CJD we would see in the country. And I remember one graph which had these estimates of how much there's going to be. And every year, every time they redid these models, the confidence intervals would reduce because they got more information and could make more accurate predictions. But so again, as more information came in, you could get better estimates. So did we know how big the problem was likely to be? Well, no. People were being very cautious, and and we've also alluded to. They thought they'd be cautious that there might be more. There might be upper estimates of numbers.
Final question on this topic of this particular question of the small risk, etc. You say you'd like to scribble all over this document now. What would you scribble?
Well, I think I actually, the most recent information. Okay, so I thought the latest information that we gave to this group, I think there was a letter I put, is either 2006 or it was really quite a recent, I thought that where we spelled out exactly, these are the number of people, this is, rather than trying to use a word that could be interpreted in a certain way, if you are actually just giving the numbers, say these are the people, this is what we've seen so far, and just letting people make their own understanding from that. rather than trying to come up with the perfect word of small, not very small, whatever. That's impossible, and people interpret it in different ways. We were also conscious of the fact this is complicated information, and I think if you look at, it's very hard to put the information across without having a lot of information, whereas ideally when you're putting information in patient information sheets, you try and keep it short and sweet and easy to read. So I do wonder whether it was all a bit complicated, but on the other hand, the information was complicated.
You've hit upon the question whether the word small should have been used at all. You've told us, I think, that the purpose of that was in a document which was, after all, intended to ensure that people took public health precautions, was to reassure people, or not to square them witless, I think was the way you put it.
Sorry.
So, if that's the purpose, do you reflect now that perhaps that's a bit paternalistic and people should be left to draw their own assumptions, knowing that you don't really know what the chances of transmission are, even if you do know that if you get it, it's pretty bad?
Yes, I think you still have to have a sort of very careful view of. You have to look at these documents very carefully and think who's looking. A range of people will be looking at them. So I said, I would try and give the information as it stands without judgment. But then people will say, "What is my risk? Is it big? Is it small?" People would ask the question. So. And all we could do is work with people who are familiar with putting out patient information on, what would a public health team be doing? My child's at a school where there's been a meningitis outbreak. What's going to, there are lots of public health messages that have to be put out. And so, we try and work with people who are experienced in putting out that kind of message to see what language you can use. So yes, with the benefit of hindsight, I can look at this and change it. I thought actually the 2006 stuff, I was looking at it and thinking that was really great. I was happy with that.
Yes. Well, can I change away from this document to another one? It's PHEN 302465. PHEN 302465. And I think I've got the wrong document. So forgive me. What I'm interested in is the document where you told us, this PHEN 40528. PHEN 40528. And if we look at the summary of this, the HPA notify, they send out questionnaires to 131 hospitals. By 5 months later, 64 hospitals have returned the questionnaires. 64 out of 131. It's just over 50%. Was that the sort of level at which you would expect those who are engaged in the protection of the public through providing health services to respond?
Well, it doesn't seem very good, but I don't know, I'd have to look at this document again to see what kind of tracing was done of these hospitals. And yeah, I mean, I don't think that summary is enough to give me a proper answer, because I need to see, so what they sent out the questionnaires, what were they told to do? Were they told to reply only if they could trace, to me, I'm not quite sure. So yes, I agree, on the face of it, it doesn't look good, but to actually get you a proper response, I'd have to look at that whole report to understand what the hospitals were being asked to do and what follow-up was being given to them.
I mean, it fits with what I suspect was a note of slight frustration in some of the answers you were giving when you were describing how the HPA, when you worked in this area, didn't always get the fullest of cooperation from Trust for their own reasons. Yeah, because it couldn't tell them what to do.
Well, I don't, yes, I mean, what I don't know is whether they were asked, from this summary, I can't see whether they were asked to return it even if they couldn't trace. So it may, so I can't tell that. And also I can't see what dialogue was had with those hospitals about why they hadn't returned, or if there was a dialogue, if there was a follow-up. I mean, it's hard to believe that there wouldn't have been a sort of chase-up and what happened. So I can't see that from that summary.
Would you expect in a survey which you conducted in the agency, whether it's Health Protection England or Public Health England or HPA or its modern manifestation, would you expect to get full cooperation, or is that just asking for something which is in practice unrealistic?
No, I think for something like this, I could imagine there being a low response rate like that, and then you chase up and you just get the response rate up, and you might, no, I wouldn't expect 100%. Unless there was a massive push and drive. So, yes, to get the NHS Trust to do something, they would have you really to do it, then there would be some sort of DH directive, some pressure from the DH to the hospitals, or from NHS, a senior NHS level down to the hospitals to say, you have to do this. So it couldn't be us telling it would have to be an NHS mechanism to say that.
And would the same apply to the notification of what might be, but might not be, a new health threat identified in some district hospital somewhere?
What you mean, like a hospital's found some strange...
So, a registrar or a consultant in a district hospital sees something odd going on, doesn't fully understand it, thinks, is there a new disease out? What does she or he do?
I would expect the consultant in that hospital, if they actually are concerned that this is something, to either come directly to us in Colindale or to go through their local public health team who would direct them to us. So, and I don't have any evidence that doesn't happen.
Well, you wouldn't have that necessarily unless the really emergent risk which you suddenly become aware of has happened, comes to light sometime afterwards.
I kind of believe, my understanding is that you've asked Susan Hopkins to ask about this, and I think she's probably in a better position to do it, to talk about those issues than me now. But I think our relationship with that people would perceive that if there's a threat, they'll come to us for support, and that's I'm not aware of any problems with that kind of issue, but I think she's giving you an in-depth response on that.
Well, thank you very much. That's all that I have to ask. Are there any questions which arise out of those exchanges?
May I just turn behind me? No.
Thank you.
Dr. Connor, is there anything you would like to say or to add to your evidence?
I think just to say that thank you for asking me to come to this inquiry. I think it's very important what you're doing, and I'm happy to contribute. And I think it's, again, my thoughts and I suppose my sympathies are with the families affected and the people affected by CJD. And I'd also like to take the opportunity to thank my colleagues. I mean, you've met James Ironside, but the panel was full of people of equally high calibre in different professional fields who really tried their best to help manage a very uncertain risk. Yeah, thank you.
Well, thank you very much for your time. I think this is the first time you've given evidence about this. And so particular thanks to you for the time you've put into it and the thought with which you've answered the questions. So thank you once again. Now we need a short break,
Yes.
don't we, of 5 or 10 minutes to put up the screen for the presentation. So shall we take a short break and say, if we say 2:30?